before some of the more people join, I will just say that there is a confusion that people think that like the purpose of this discussion is to discuss only about Viva. Okay, so the point is that there is no clear differentiation that what knowledge you exactly need in written and what knowledge what you exactly need in Viva. Okay, so the main difference between the two is the way being asked, because in actually written examination sometimes more depth, more minute details are being asked. Okay, whether they are written like SAQs exam or MCQs exam. Rather in oral exam, mainly the main concepts are being asked. Okay, but there is no but there is no clear-cut differentiation. So my point of view is that if you have clear concept about any subject, then it will be easier for you to go in the minor details. Okay, so and another thing is that some people just try to dissect this difference between written and Viva, and what happens, they are confused and they don't have the clear concept about that topic. Maybe they are able to pass through the MCQs or written part, and when they are being counter questioned about the concept in oral exam, they fail. Okay, so that's what I just have learned in my career and appearing in the international exam, as well as failing again and again in the FCPS exam. Okay, so that's what I learned, and I just want to spread it back to the people with whom I'm attached. Okay, so that is just, I wanted to say a few words. Just try to cover the subject in a way that in whatever way it's being asked, you are able to answer. Okay, so we will be discussing the topic of pain in a slightly different way. What is pain? Okay, so can anyone tell me what is pain? Asim bhai, would you like to tell?
So pain is an unpleasant sensory and emotional experience associated with or resembling that associated with potential or actual tissue damage.
Okay, so how can you classify pain?
Acute pain and chronic pain.
Okay, this is one category. Other?
Other like neuropathic pain and visceral pain.
No, neuropathic versus nociceptive.
Nociceptive, right.
Okay, visceral versus somatic. Okay, what else?
Right.
And then according to the severity, according to the character, burning pain, pricking pain. Okay, so like this is how you can classify or just make different categories of pain. Am I right?
Right.
So when we pinch, okay, when we pinch or there is any pain sensation, from where it starts and where it goes?
So the first order neuron takes the pain stimulus from the pain receptor to the dorsal root ganglion. From the dorsal root ganglion, second order neuron starts and it decussates in the spinal cord and travels through the spinal thalamic tract to the thalamus. And the third order neuron.
Okay. Just a small thing. First step, you directly told about fibers. What is the first thing when there is pinch? The nociceptors are
activated,
and there is generation of action potential. and then it is transmitted through which fibers?
A delta and C fibers.
A delta for fast pain, okay,
Pain, and C for slow pain. Yes.
slow pain, and the other this step is called as, what is this step called as?
Transduction.
Transduction. Okay, so the next step starts from here. It's called as
Transmission.
transmission. Okay, so transmission from here up to the brain, it's all transmission. Okay,
Right.
from whatever pathway it is crossed to the other side. Okay, and then from there it is going up and reaching up to this one, like
somatosensory cortex.
yes,
The
but
cingulate gyrus, central, postcentral gyrus, and Sylvian fissure.
thalamus, and then like from here to from the periphery to the spinal cord is first order. Then from there, interneurons.
Spinal cord to thalamus is second order, and from
Second order,
thalamus to somatosensory cortex is the third order.
Third order. Okay. So and the last step is perception. Okay, perception in the brain. But in between, there is the most important step, which is called as first step
Modulation.
is, yes, modulation. Okay, so first step is transduction, second step is transmission, and the fourth step is perception, and in between, the father of everything, that is modulation. Okay,
sir.
Because we cannot do much in transduction, that we can just put local anesthesia and it will block the transduction and transmission as well. Okay, and then perception is in the central nervous system. So all the medications of antidepressant, antiplatelets, or the atypical things, they are acting on perception. Even paracetamol is acting on the perception. Central, it has central effect. What is the mechanism of action of paracetamol? How can you explain? Yes.
I don't remember, sir.
Okay, Asim bhai, can you just tell what is difference between the mechanism of action of paracetamol and NSAIDs? Asim bhai, can you hear?
Yes, NSAIDs are COX-1 and COX-2 inhibitors.
Let him speak.
NSAID basically prostaglandin inhibitors.
No.
And
so what is different? And then what about paracetamol?
This is also, but this is centrally acting basically. NSAID is on the substance P mediate. This stop the.
No, NSAIDs are COX-1 and COX-2 inhibitors, and paracetamol is COX-3 inhibitor in central nervous system. Okay, and it acts on the perception, and it has also effect on hypothalamus, and it changes the response. Okay, and it has antipyretic effect, central acting antipyretic effect. Does paracetamol has any anti-inflammatory effect?
No effect on the anti-inflammatory effect.
Anti-inflammatory effect. Okay, and what about this COX-1 and COX-2? What is difference between COX-1 and COX-2? Anyone knows about it? COX-1 is everywhere. Okay, COX-1 is everywhere, and COX-2 is appreciated in sites of inflammation. Okay, so that's why actually our main target is COX-2. That's why we use this word selective COX-2 inhibitors. So they are free from which effects which are more pronounced in selective COX-1 and non-selective COX-1, COX-2 inhibitors?
The GI side effects?
Yes, GI. But because the other effects on kidneys are the same. Okay. There is no protection from that. Rather, some selective COX-2 inhibitors were, they are now out of the practice because of cardiac arrhythmias, okay, and ischemia. So they are not being used, Rofecoxib or something, some medicine, I don't know exactly. So this is just baseline information which you should be knowing a little bit about this paracetamol and NSAID, okay, and NSAID. Yes, Zishan, would you like to say something?
Yes, sir. Sir, I wanted to ask about modulation. What is actually meant by modulation?
I'm just going towards that thing. Okay, I'm just going towards that thing. And what about this anti-inflammatory effect of COX inhibitors? How does they do? Yes. Please, who will be telling? Jamil, can you tell? How does this effect of anti-inflammation occurs by COX-1, COX-2 inhibitors, these anti-inflammatory, how do they work?
Actually, sir, they affect on the metabolism of and the what is the C to TXA?
Prostaglandins from
Prostaglandin on the cell membrane. Yes, cell membrane. Then it inhibit the. Actually, the forget TXA. What is that?
Just think logically. Whenever there is a trauma, okay.
Yeah.
Thrombosin.
There is release of these inflammatory mediators. Okay.
Yeah, by cell membrane.
That is what is responsible for the what is called the question which Zishan asked, modulation. They are responsible for this primary and secondary hyperalgesia. Okay, because this modulation is just like a modulator. Either there is some, you can say there is a switch which can either be increased or decreased. Okay, so modulation occurs at every step. Okay.
Yeah, I remember arachidonic acid metabolism.
Arachidonic acid, like ultimately prostaglandins synthesis.
Prostaglandin, yes,
Okay?
yes. Suppose prostaglandin, yes. Different, you know.
Because there are two steps there in the periphery. There is one is called as primary hyperalgesia, where there is these PGE2, leukotrienes, bradykinin, histamine. Okay, and then secondary hyperalgesia, which is called as a triple response. What is the triple response? You see this, the local edema occurs. Initially, there is no swelling, okay? And later on, there is increased redness, swelling, okay? This sensitivity increased. So this is called as secondary hyperalgesia. Okay? So when you are giving anti-inflammatory, and this is the concept of preemptive analgesia as well. When you are using NSAIDs, as preemptive analgesia, the mechanism is that you are make this response to the pain blunt. Okay, so what will be result? Everyone is understanding? Can you hear me? Yes.
Yes, sir.
Okay, so so this is just a concept of modulation at the peripheral space. Okay, so primary and secondary hyperalgesia. What else occurs, which is a very common thing everyone asks, everyone knows about it, but maybe what is the gate control theory?
Sir, gate control theory is basically when we activate one gate is open, the other is closed. when we activate one fiber, the transmission from the other, the first fiber will be stopped. Like when we activate in 10, it is applicable on the 10s, like transcutaneous and electrical nerve stimulation.
Just a second. You are right, but just explain a little bit. It is,
Yes, sir.
it is
May
like, just a second, Zishan. Okay, please speak out.
Sir, substantia gelatinosa is the main carrier that transmits the pain through the spinal cord to the central nervous system. Now, the pain gate in the substantia gelatinosa is opened by the slower pain fiber that are the A delta and C fibers, and it is closed by the tactile stimulating fibers like A beta fibers when the
Yes.
stimulus from those fibers is coming.
Yes. So actually, in a simple and a funny way, that actually
Yes.
you are bribing. Okay, you are just bribing the big fibers. Please calm down, calm down. Don't send messages to the father. Okay. So it is just like you are bribing your brother or sister not to tell to the father. Okay. So
Yes.
this is the mechanism, that the door which is through which it's going, you are as soon as there is some noxious stimulus, you just start rubbing. So when you are rubbing, you are stimulating A beta fibers. Okay. So when the
Yes, sir.
beta fibers are stimulated, they are closing the so-called gate present, and it is not letting the sensations to go up. So now comes to the what are the different modalities which are being used on this gate control theory.
So TENS theory is being used using the gate theory for pain management.
Only TENS?
Sir,
Acupuncture
another
also.
Acupuncture, acupressure.
Yes.
What else?
Acupressure.
So spinal cord stimulation is also the same thing.
Spinal cord stimulation is also the same. If I'm not wrong, I don't have too much detail, but spinal cord stimulation, I suppose, also is the same category. Okay. So this is how it. And another thing is, what about this substance P release? Is it the same thing?
So substance P is released at the level of receptors.
This substance P inhibitors, like there is, you see, capsicum or something cream like that.
Yes, it is. Yes, it's
red chili, or
Red
yeah,
chili.
it works at peripheral receptors. Mediator released in response of the pain. But if we give any substance that now stimulate or irritate the receptors, then gradually it releases the substance P, and gradually it's the excretion of or depot of the substance P depleted after some time.
No, it's not releasing, Jamil, it's inhibiting. Okay.
No, we first give any stimulus
just
to the receptors, like capstan scheme. It's like a burning sensation. It will excrete substance P in the start, and then gradually it's deplete the depot of the substance P from the receptors, or decrease the sensitivity to the receptors. What I understood. If somebody can explain in other ways, no,
it's decreasing. You are saying that it is releasing and exhausting, but actually it's decreasing. Okay. Its act on this substance P is responsible for the triple response.
Triple response is increase the pain also, it cause the pain, and aggravate the pain response also to the receptors. Means it's more sensitize the receptors also.
Yes. So this is decreasing it. The substance P inhibitors, this is not releasing it.
Okay.
Okay. So this is the peripheral. Now there is a concept of central modulation. Okay. So actually, I don't have very good concept of this central modulation. Rabia, do you know about it?
Yes, sir. Sir, central modulation is basically it is a part of modulation which act at the level of spinal and supraspinal level. There are two. It is categorized into inhibition and facilitation. Inhibition is done at the every segmental level, and also supraspinal level. And facilitation is done. There are three categories in facilitation, like wind-up phenomena, enhancement of receptive field, and hyperexcitability of the reflexes. So these mechanisms are used to modify or enhance the pain perception in the brain. So
yes. As you told that this is wind up and sensitization of second order neurons. This occurs in the spinal cord. Okay.
Yes.
And then there is second is receptive field expansion.
Field enhancement. Yes, sir.
Okay. And the third one is hyper excitability of
reflexes
response.
That is in other word, sensitization.
Yes, sensitization. Okay. So, and then there is one very important modulation control. What is that one? Descending inhibitory.
Yes.
Descending inhibitory. Okay. So, what medications act on this descending inhibitory?
Sir, ketamine, NMDA receptor.
Yes.
NSAID, spinal opioids.
NSAIDs? How NSAIDs? No. I don't think so. NSAID is here. Spinal opioids, yes. Okay. And ketamine.
And alpha-2 agonist.
Yes. Centrally, that is for the response to the pain. Now we will, from here, next step, we will go to the response of pain. What is the response of the body to the pain? Okay. So, this is how it is modulated. So transduction, transmission, modulation,
and perception.
Usually, this is the whole of the pain, and if you know that what medications are acting at what level, like opioids, what is the site of action of opioids?
Sir, they act on the receptors.
Opioid receptors in the central nervous
The
system.
dorsal horn of the spinal cord.
Neuroreceptors in the.
There's one step of doctor. This Technospark. What is your name?
Sir, Arif baat kar raha hu.
Arif. Okay, Dr. Arif. So this spinal cord, this opioids have pain relief at different levels. Okay. So one of them is, you have told, this spinal cord.
Dorsal
horn of the spinal cord. Not only dorsal horn. Whole of the, there are opioid receptors. Okay. And they are doing this modulation which Rabia was just telling. Okay. And one of the effect of opioids is perception. Okay. Opioid effect on the central nervous system and modify the response to the pain. So it affects the perception. Okay. That's why have any of you received opioids?
Sir, I have received.
Okay, so actually, what was the response? How did you feel?
Sir, actually, I have chronic backache and I had underwent spinal surgery 4 years back. So off and on.
Did you receive?
Sir, usually, sir, initially, जब मैं post-op के बाद recovery में
we are talking only in English, Arif. Please, sorry. Okay. So I'm sorry. I'm just going a little. I just wanted to the point which I just wanted to tell is that the pain when we receive opioids, actually the pain is there. The perception, we are not feeling it. Okay. So this is the concept of like opioids. Okay, so so opioids, and there is also in our body there are natural opioids. What are those called, Rabia?
Sir, enkephalin and
Endorphins.
endorphins.
Yes. Okay, so this is just a broad concept. So the medicines like ketamine also affect on central nervous system, on perception, and they also have NMDA receptors, and it has descending inhibition. Okay, so this is also the effect. And then what else? Dexmedetomidine, it is affecting by changing the sympathetic response to pain. Okay, that decreasing, it has centrally acting presynaptic release of it. It decreases the release of sympathetic discharge. Okay, presynaptic alpha 1 agonist, and it has inhibitory control. So what else? Common medications what about lidocaine? Lidocaine also acts by membrane stabilizing. Okay, and also decreasing the sympathetic response to pain. So these are the common: parastamal, NSAIDs, opioids, and opioids receptors mu, kappa, delta, and they are at different parts of brain spinal cord. Okay, and the central medications which are being used usually in the chronic pain and this neuropathic pain, and they are some of them are calcium channel blockers, some of them are sodium channel blockers like anti-epileptics. Okay, and these antidepressants increase the catecholamines, they decrease the reuptake. Okay, like serotonin or other catecholamines. Okay, so that's just a basic concept of pain, and now we will just try to go into some of the aspects of pain management in that way, that because my aim was to just cover the whole of the topic. It is a very big topic. I'm trying to find out a way in which I'm able to cover most of the aspect. But actually, if you know up till now, usual management of acute pain and chronic pain will be like that. Very quickly, Rabia, in 1 or 2 minutes, can you just explain the detrimental effects of pain? Or Zishan, would you like to say, please?
Yes, sir. Sir, the effect of pain on different systems are on CVS. They lead to increase in the catecholamines, leading to tachycardia and hypertension, and this can lead to disturbance of the demand and supply. On GI system, they lead to gastric stasis, and ultimately constipation. And on respiratory system, there is increase in the respiratory rate, and also due to splinting, atelectasis and VQ mismatches and hypoxemia. And other is on the endocrine system, it leads to release of the different catabolic hormones like this one, glucagon, glucocorticoids, catecholamines, ADH, activation of RAS, so leading to salt and water retention, and catabolism and inhibition of anabolism, leading to hyperglycemia. And further on the other systems, like
usually the main effects are the sympathetic response,
yes.
Catabolism and anti-anabolic and catabolic effects. Okay,
yes.
And psychological effects.
psychologically, the anxiety, depression, social disconnection, and also immune suppression, and also
Respiratory system.
hypercoagulability, platelet dysfunction.
Yes. So
Yes.
this is just a summary. Okay.
Yes.
So now, our main aim of pain multimodal analgesia will be focusing not only towards this thing and towards also affecting the harmful effects. Okay. Yes. Okay. So now, what about differentiation between what is neuropathic pain? How will you define neuropathic pain, and how what are the different neuropathic pain syndromes we deal, and how acute pain can lead to chronic and neuropathic pain?
Sir, neuropathic, basically, sir, there are different types of pains: nociceptive pain, neuropathic pain, and there can be mixture of the pain, both of pain can exist at the same time. So nociceptive pain is the pain from the bones, skins, muscles, and mucosa. And
No.
neuropathic pain is
Neuropathic, don't mix up nociceptic pain like that. What is neuropathic pain?
neuropathic pain is the pain involved peripheral or central neurons, leading to peripheral and central neuronal disorders.
Okay, now, Meher, can you tell me what are different neuropathic pain syndromes which we anesthetists deal with?
So different neuropathic pains are phantom limb pain, postherpetic neuralgia, stroke, after a stroke, spinal cord injury, multiple sclerosis.
Okay. Just tell me one thing. What about chronic post-surgical pain? Is it neuropathic pain?
Yes, sir, it is neuropathic pain.
Okay. So what are the basic principles by which you are treating neuropathic pain?
Basic principles, sir, by a multimodal approach.
Okay. So no. Okay, fine. What is WHO step ladder for actually pain management? Because for acute pain, it is starting from the maximum and going back gradually. Okay. And
Yes.
the WHO step ladder for chronic pain is the other way around.
Minimum to maximum.
From minimum to maximum. Okay. So what are the usual medications which we use for this one neuropathic pain?
So in this we use opioids, tricyclic antidepressant, and
Opioids are opioids the first line in neuropathic pain?
no, sir. But
Then why you are using at first? You started your answer with opioids. So this is not the first of all you will have to assess the scenario. Okay, that what is the reason for this neuropathic pain, and then you will be chalking out the plan. Usually they are starting from simple parastamal, okay, NSAIDs, and then you go towards because there is definitely psychological involvement. For that, usually they are starting antidepressants, okay, antidepressant, antiepileptics. So you told this one for diabetic neuropathic pain, what is the first drug of choice?
Duloxetine.
Duloxetine. Okay. Duloxetine.
Yes.
And what about this trigeminal neuralgia?
Carbamazepine.
carbamazepine is the first line.
Okay, and this one, what is duloxetine, by the way?
Sir,
So
it is
SSRI.
dual. No,
No.
it is no. It is dual. It is
It-
serotonin and norepinephrine reuptake
It
inhibitor.
is SNRI. Okay. It is SNRI. Okay. So it is SNRI. And this carbamazepine, what is carbamazepine?
So it is an anticonvulsant.
Anticonvulsants. Okay. So, and which anticonvulsant we use for the for in our acute pain management?
Gabapentin.
Gabapentin.
Gabapentin. Okay. And another sub group for that, another medicine from that group is Pregabalin. Okay.
Pregabalin.
And they are usually there. What is the mechanism of action of gabapentin?
Sir, it is calcium channel block.
You know, Dr. Arif, the problem with there is some problem with your mic. So please try to fix it. Or if you are using headphones, please remove them because it's distorting. So what is the mechanism of action of gabapentin? Gabapentin act on voltage gated calcium channel.
Calcium channel blockers.
Okay. And so it has opioid sparing effect, but it has sedation. Okay, it has in some people they are very sensitive to its sedative effects. Okay, so just a second. Okay, so actually this neuropathic pain, there is involvement of central nervous system. Okay, so there are certain features which are present in neuropathic pain, which are hyperalgesia, hypoalgesia, allodynia, okay, anesthesia dolorosa. In different categories, they can be there. There are different terminologies which you should be knowing. This is because cramming stuff. I'm skipping it for a while because we are short of time. I'm just trying. We will discuss in detail these pain syndrome because it's not possible to cover them in one go. Usually, there is common things which you can tell when you are being asked for any pain, chronic pain, and this neuropathic pain. Okay. So if we just go one by one, what about phantom limb pain?
Sir, it is pain sensation originating from an amputated limb or a...
Just let anyone else get a chance. Zishan, would you like to say something? What is this phantom limb pain?
Sir, pain sensation in the amputated limb is called phantom limb pain.
Okay, so how it is how it is originated?
I don't remember that.
What is the mechanism? Meher, would you like to tell?
So in this, there will be the overexpression of the receptors, which are sensitive to any non-painful stimuli and
if someone asks you how phantom limb pain develops, there is actually thing is that there is when they are cutting, okay, there is after that there is desensitization, sorry, oversensitization, and there is like you can say neurological damage, okay, and needing to neuroma formation. Okay, so this is one concept, peripheral mechanism. Okay, this is one thing. When this because that place is now empty, there is remapping in the brain, in the sensory system, sensory areas. So there is problem in the remapping. Okay, there is a problem in the remapping, and this one they are unable to readjust this thing. So the brain is still sensing that area. So this is the in the central nervous system. And what happens in the spinal cord? So the same mechanism which occurs usually in the modulation. So there is like a decrease inhibitory response. So there is increase in the pain sensation. Okay, the same mechanism which we discussed for the modulation in the spinal cord. This receptive field expansion and wide dynamic range, that is the involvement.
Wind-up phenomena, hyperexcitability, receptive field enhancement.
Yes. So this is if someone asks you what is phantom limb pain, it's a sort of chronic pain which has neuropathic origin, and it occurs because of this thing. If you are able to tell this thing, that will be how to manage it.
So by a multidisciplinary approach, pharmacotherapy, good multimodal analgesia of the system post-operatively. In this, we can give patient paracetamol, NSAID, opiates, antidepressant, and SNRI, and non-pharmacotherapy, acupuncture, TENS, physiotherapy, early mobilization.
You have not told the main thing, which is like a separate thing which is there for phantom limb pain. What is the specific thing which is not?
Mirror box.
Mirror box. Mirror box therapy. Okay, mirror box therapy, which is being used for this one for phantom limb pain. Okay. And like what in which patients there will be more chances of phantom limb pain?
So severe pain preoperatively, or in this pain located in the distal part of the amputated limb, in this in this resistant to conventional analgesic opiates, and in those patients.
Is there any role of this one epidural or spinal in phantom limb pain if you are giving it preoperatively?
Yes, sir. In this, if we give preemptive analgesia, then there are chances less pain.
Okay.
Chances of
so you did not mention this thing in your answer. So
yes,
like this is how they will be asking you in this scenario about this thing. And the other thing, what is post-herpetic neuralgia? Just a second, who will tell? Asim bhai, would you like to tell what is post-herpetic neuralgia? Zishan, do you know about post-herpetic neuralgia? Rabia, would you like to tell?
Sir, it is basically pain which persists after the 3 months after the viral infection due to herpes zoster. It is the herpes zoster virus. After patient gets infected, it's become dormant in the dorsal root ganglion, and when there is a decrease in immunity or due to any condition, the virus reactivates and cause inflammation of that dorsal root ganglion and that particular nerve, leading to shingle formations, which are skin eruptions, and inflammation of the pain of that area. So there is
you are telling about shingles. Okay, this is you are telling about shingles. If someone is asking you about post-herpetic neuralgia, you have to tell that it is persistent, like you started, you tell that it is persistent pain, which is usually like in the form of neuropathic pain after this apparent healing of the shingles. caused by varicella zoster. Okay, because this pathology is related to shingles, development of shingles, and shingles is unilateral segmental involvement of spinal cord, or it what other nerve it involves?
Sir, that ophthalmic division of trigeminal nerve.
Okay. Okay, so that is also part of it. So similar, there is no specific management for post-herpetic neuralgia, except if you have given antivirals.
In the active, yes, in acute disease, if we give the antivirals, the chances of post-herpetic neuralgia decreases.
Yes, and any patient which has depressed immunity, any patient which has immunosuppression by any medication, something, they will be at more risk. Okay.
Yes,
and this is all about post-herpetic neuralgia. Otherwise, the same as you say, there can be a combination of anticonvulsant, antidepressants. Okay.
Local applicants. Yes, sir. And
Yes.
all the medication which we mentioned before, like amitriptyline, pregabalin, and TENS therapy, simple analgesics, and intrathecal opioids can also be given.
Yes. So these are the there is a role of capsaicin cream.
Yes, sir. Local application of the, I mentioned it before.
Okay. So if they will be asking you, you can just answer. What about the third one which is being asked is trigeminal neuralgia. So how will you tell about trigeminal neuralgia?
Sir, it is basically.
एक second, just Rabia, just a second. You are on the back. Asim bhai, would you like to say, please? If anyone wants to discuss, please raise the hand quickly. Okay, Meher, what is trigeminal neuralgia?
So it is a classically unilateral and located in the mandibular or maxillary distribution of the trigeminal nerve. It is of electric. It is a electric shock quality with the episode lasting from seconds to minute, and often it is provoked by brushing.
This is the beauty of reproducing a crammed word from the book. If your cycle stopped somewhere, you will not be able to regenerate. Well, you did not mention the word neuropathic pain. You did not mention the word severe pain in the distribution of trigeminal nerve. Okay, just try to be simple. Okay, I'm not saying that you have told the wrong thing, but if God forbid in exam tension you are able to miss one or two words, what will you do? And that's what happens in the exam. If you know what is trigeminal neuralgia, I guarantee you will never forget. Okay, but if you try to recall the words of the book, you can stuck. So it's a neuropathic pain. Number one, it's a severe, lancinating, crushing pain in the distribution of trigeminal. Like you are telling it is episodic. Okay, fine. So rather than from minutes to this is exactly, I can still recall the words from Manhus Morgan Sharif. Okay. From where you are recalling. You see, people, when I am just trying to make them away from this book, people think I have not read it. I am the product of that bloody nonsense book. I'm sorry to be a little hard, but because the problem is that it is so unrealistic book that it will damage you when you need it the most and you are unable to recall it. So I'm sorry, I am a little bit distracted for it, but don't forget that try to understand the concept. If you are able to understand the concept, you will be able to tell it in a better way. Okay, Meher, you are sorry for shouldering, like you just moving you very hard, but it is a
no, sir.
Okay, so how usually these all pain, they are diagnosed, there is no specific diagnostic test, a clinical diagnosis. Okay. And usually you will not find any other neurological deficit or any other thing, because it can be combination of any other thing. Okay. So severe pain, it will be not related to any tissue injury. Okay. And then you will be finding it in a distribution of trigeminal nerve. And then you can do some MRI. There will be some finding in like evoked potentials or MRI, but usually it is a clinical diagnosis. And then what will you treat? Give the treatment, the same things which you are, but first you say, in addition to the usual paracetamol and NSAID, you will be giving carbamazepine. Okay. Carbamazepine is the drug of choice for this thing. And if everything is failing, there are some like sympathetic block or surgical management. Okay. Okay.
Yes, sir.
So just remember the word microvascular decompression.
Decompression of the Gazerian ganglia.
Of the Gazerian ganglia. Okay. So this is in that way they will be asking you this question. The last one I have brought it at the end is CRPS. What is CRPS? Who would like to tell? Anyone wants to tell? Otherwise, I will hand over to Rabia. Anyone wants to tell what is CRPS?
Yes, sir, I will tell you.
Yes, okay. But
So
the cheating is not allowed for animals other than me.
No, I'm not cheating this. I'm giving you this pain which is continual in nature.
Okay.
There is one and there are sign and symptoms, 4 sign and 4 symptoms. So we have to see rule out if there is one
again, if someone asks you what is CRPS, what will you start? You are doing the same mistake as Meher Ali just said it. Is it a neuropathic pain?
Yes.
So you have to start your sentence with neuropathic pain.
So it is a neuropathic pain. It is a chronic regional pain syndrome. Okay. It's characterized by there's 2 types, type 1 and type 2. Type 1 in which there is no actual nerve damage, and type 2 there is a actual nerve damage. And there are some clinical criteria to diagnose this problem, and in which there is the pain which is continuous in nature, which is disproportionate to the emphatic event.
Sorry, Asim bhai, I am again interrupting you. There is one component which you have not told, and it's very important. That is the involvement of sympathetic system, because I was just trying to listen from you this thing, that it is a chronic pain. Okay, it's a like a syndrome. It is involving multiple systems. There may be or may be direct involvement of nerve. Usually it can follow a tissue injury or tissue trauma. If any direct nerve injury is identified, we label it as CRPS2. Okay. And usually the main component, there is involvement of sympathetic, or there is some component of sympathetic nervous system, because whatever features you are telling later on, they are related to the exaggerated response of sympathetic system. Am I right?
Yes.
So that's how that's how the definition of anything is being made. And the exam, people think that examiners are expecting a clear-cut British English definition from any book. It's not like that. If you are able to make them understand the concept, and if you have told all the components, they will not ask you anything. But if you missed, like in this words, you have missed the most important thing. Okay. So now there will be some signs and some symptoms. There is one criteria for it. It's called as Budapest Criteria. What is that one?
Yes, there are categories with the sensory, vasomotor, pseudomotor, and motor.
Okay.
And in this, there is sign in sensory. There is hyperalgesia and allodynia. And in this vasomotor, there's changes in skin or temperature change, and in pseudomotor there is this color change with edema, sweating, and with motor with this trophic, there's a decrease in range of motion, and there is changes in color of hair, skin, nail. This all are the criteria.
Okay.
So the criteria it follows that like that. If there is one sign in 2 or more categories, or one symptom in 3 or more categories, so it is labeled as a CRPS.
2 symptoms in 2, 3 or more categories. One
No,
sign
one
in 2 or
sign,
more
one,
categories.
yeah, and one symptom in 3 or more categories.
It's 2 symptoms, no? 2
No,
symptoms in
it's one symptom.
One symptom.
Okay.
One symptom in 3 of the 4 of the categories, and one sign in 2 or more. Just a second, there is a difference. Sign are 2 and symptoms are 1.
2 signs.
2
No, it's
One
signs.
sign in 2.
one
Just a
sign.
second. Just a
One
second.
sign in 2 or more.
Just let me clear. One symptoms from 3 of the 4 categories, and
Yes.
one
3 or more.
sign from 2 or more categories.
Okay.
So that is, one is sensory, one is motor, one is pseudomotor, and one is vasomotor. Vasomotor in the form of temperature, pseudomotor in the form of edema, okay, and motor trophic changes with the changes in the skin, nail, okay. And if the patient is telling you that is symptom, actually, I don't know how they have created this thing, but actually it is very like confusing, in the sense that the same thing almost, it's the sign as well as symptoms. So how they are differentiating it and how they are tackling it, it actually doesn't make any sense.
Like a patient will tell that I'm feeling the pricking pain and I'm feeling hyperalgesia like of condition, and we will notice the allodynia and hyperalgesia. Patient will say
History will
that
tell. The history will tell.
color, temperature, and we will notice that color and and it's like that. Patient will say that I am having there is some edema and sweating on my hand, like there is some watery, my hands are watery, and we will notice the asymmetrical edema and like that. In the same way, they will say that we are feeling weak. I'm feeling weakness, and there is mere heart, like my hands and nails and skin is changes are there, and we will notice in the form of like decreased range of motion and dystonia and hair and nail changes.
Okay,
so it's
Yes,
like that.
the major thing which is the diagnostic is anything he is taking analgesia, it is not working. This is the major component. You can exclude all the things, because anything he's taking like opioid, analgesia, NSAID, paracetamol, it will not work. Only the sympathetic block will work on this.
Yes.
Or
Okay.
the IVR regional
Okay,
block.
so what will be the treatment modalities?
Sir, that would be treatment would be according to psychosocial model, involvement of multidisciplinary team. The treatment will be categorized into non-pharmacological and pharmacological. Non-pharmacological treatment is that reassurance, education, rehabilitation, physiotherapy, psychotherapy, and pharmacological is starting from the simple analgesics like paracetamol and NSAIDs up to the pain like these neuropathic antidepressant, anticonvulsants, then to regional therapies these are sympathetic blocks, and also like lumbar plexus blocks.
Intrathecal baclofen.
Yes, intrathecal baclofen and opioids are also being used.
Okay, and one thing, because we have missed, I think when we were discussing, even there is destruction of even bones. Okay, so even there is involvement even up to the soft tissues, even up to the bones. So in that case, the pain will be even more severe. And if there is involvement of bone, they will be needing some like bisphosphonates or things like that. Okay. And if there is some immunological involvement, maybe some role of steroids. Usually it's not it will be in isolated like anti-TNF or something like that. Okay. So actually the good thing is that if you tell in a systematic way, you can say anything related to pain medicine, which from where we started actually. That's why I started from there, that you should be knowing what are the different modalities. And then if you organize your answer in a way that you will be, the answer will be combination of all the medications which are being used. But how you have to, just this is the only the way you will be getting the node of the examiner. Okay, because actually they are not expecting very high level things in FCPS anesthesia, because it's a subspecialty. Okay, but whenever they are asking you a question of any chronic pain syndrome, be methodical. I try to say that it is not correlating with the tissue damage. This is the main concept. And as we discussed few days ago about when we were discussing this, rather yesterday, was anesthesia plan, that if you are not treating the acute pain, there will be a chances of going in chronic pain. So that's why acute pain management is so important. And if you have a concept that there are 4 steps, now I'm just trying to summarize what we have discussed up till now. Transduction, we are giving local. Okay. That's why local infiltration is so important, and sometimes surgeons or we are unable to make them realize that before initiating the actual this one stimulus, if you are able to giving some local infiltration, that will help a lot. Okay, so that will be the first step you are blocking. Then you are giving some before that, even you are giving some parastamal, you are giving gabapentin, you are giving NSAIDs, you are just trying to the so-called the response which will be there after some time. So you are just trying to make the guards which will be fighting, just make them sedated and slept so that their response is decreased. Okay, then you are giving this one like the medicines on the background, like medicines like lidocaine or dexmedetomidine, okay, or ketamine, which is blunting the response to the pain. Okay, and then you are giving NSAIDs to reduce the intraoperatively. If you are giving it, it is also reducing the working as anti-inflammatory and analgesic. Parastamal is acting on the perception. So that is how you will be dealing with acute pain. That the concept of acute pain management is slap hard and start, and then gradually come back. And in chronic pain, you gradually you increase to the maximum. So this is the main concept of managing this one acute pain, and ranging from the one terminology they can ask you is chronic post-surgical pain. It's the same thing. If you are not treating the acute pain nicely, the patient can go in chronic post-surgical pain. We discussed about yesterday which surgeries are prone. Even simplest surgeries are mastectomy, inguinal hernia, and this one thoracotomy. They have tendency to go to the chronic pain, and there are certain patient factor, anesthetic factor, and surgical factor which will lead to the development of chronic post-surgical pain. One component which is now missing is this one, cancer pain. So what are something extra to this what we have discussed up till now? Anyone would like to say some words about cancer pain management?
So again, the palliative care would be there for cancer patients.
One thing, and some sympathetic block, some neurolytic block. Okay.
Neurolytic block.
Some neurolytic blocks will be used. Neurolytic blocks, some words about neurolytic blocks. They are, what are the mechanism? They are doing the tissue trauma, the tissue damage, nerve damage. Nerve damage by denaturation of the protein or the fatty acids. Okay, so either we are using alcohol or phenol. Alcohol is painful and phenol is painless. Okay, And another difference, Rabia, which I forgot, if you just recall it for our everyone, one is hypobaric and one is hyperbaric. I think alcohol is hypobaric and phenol is hyperbaric. Am I right?
Yes, sir.
Yes, sir.
So what will be the mechanism that if you the disease so the if you are giving it, you have to keep the that portion up. I just am trying to recall what is the concept. Is it like this?
Yes, sir. For hyperbaric solution, the
Yes.
part of the involved should be kept up, and for hyperbaric solution, it should be down.
Yes. Okay. So this is a concept for neurolytic. Usually, neurolytic blocks are used after one sympathetic block. Usually, okay, and then they are giving it neurolytic. And celiac plexus block and for this pancreatic pain. Okay, and what else? There are two other modalities which are we have not discussed. One is cryoanalgesia and one is radiofrequency ablation. Okay, which are also being used in cancer pain sometimes. Cryoanalgesia is how is what is the, like if someone asks you, because it will be a small portion. So what is cryoanalgesia?
Sir, it is basically a kind of neurolysis by freezing the nerve.
Freezing the nerve, and what will be the working principle?
So working principle would be it's
no. If a highly pressurized gas is allowed to expand, there is
allowed
cooling.
to release from a constriction, so it will expand
Cooling,
and yes,
it will produce cooling, and that is Joule-Thomson effect. Okay.
Okay, sir.
Joule-Thomson effect, and liquid nitrogen is being used, and it is cryoanalgesia. And what is the principle for radiofrequency ablation?
Sir, for principle I forgot, but it's like producing heat by a current on a tip of a probe and ablating a nerve at that point.
Like it is radiofrequency ablation has multiple use in chronic pain, in this one treating cardiac arrhythmias. Okay, there is one EP electrophysiological study, and they find the area of the point where from where this abnormal focus is generating, and they ablate it. So this is one thing you should just keep in mind, in my mind, that radiofrequency ablation not only used in chronic pain, it has multiple other use. Okay, and radiofrequency ablation, the main principle is the generation of heat by, you should just, if someone can recall, is it what sort of current is it? I don't remember, high frequency or low frequency or something like that. Okay.
Sir, heat is produced by the current that flows from an electric and flow to in a electrode, and it is concentrated on the tip of the electrode, and the heat is produced to just damage the nerve.
The localized area. It is also radiofrequency ablation is also done for the sympathetic blocks. Sorry, through the sympathetic nervous system.
Lumbar sympathectomies and dorsal
root. Yes. Okay, so even they are doing it and highly specialized in the for the this one in the cervical area as well. Okay, so this is radiofrequency ablation, cryoanalgesia, neurolytic blocks. What else is left? In the cancer pain, there are components related to end of life care support. There are related to the like. A component are not only related to anesthesia, they are related to relieving of the symptoms or relieving of the symptoms which are causing the pain. So like generation of colostomies or things are also there. And there is also concern of opioid addiction. Okay, opioid addiction is there, and rest is the same chronic pain. So Zishan, as per your, I have just tried to cover as much components of pain as much were possible in this time. Any other thing which you want to ask? Usually they will be yes, Jamil. Very good point you told. What are the red flag signs in the back pain?
सर उसका निमोनिक हमने जो बनाया है वो टूना फिश है. Trauma, unexplained weight loss, neurological damage, age above 50. IV drug abuser, steroid use, malignancy, history of malignancy, and one is missing.
Just
F
try
Fever.
a little slow. Can
Fever. Yes, sir. It's trauma.
What is the
Neurologic.
concept of red flags? And listen, relax. What is the concept of red flag?
Don't know the exact concept, but it's written that whenever there is a red flag, you should go for imaging first.
Like you have this is usually for specialized referral, and there are chances of neurological damage. Okay. So now
Yes, sir.
what will be the, like you are saying, trauma? There is history of trauma. This is one thing. Number 2.
Unexplained weight loss.
Unexplained weight loss. Okay. Number 3.
Neurological damage.
Neurological damage. Okay.
Age above 50.
Age above 50.
Fever.
Okay.
Intravenous drug abuser.
Okay.
Steroid user.
Steroid user.
And history of malignancy or chemotherapy.
Okay. So these are the red flag signs in the in the chronic backache. Okay. So
I just want to add one thing. Age not only above than 50, but extreme of age less than 60, above than 55.
Okay.
Less than 20. Extremes of age less than 20 and more than 55.
Okay.
Okay. So there is one more they can ask you about. This is least likely to be asked in MCPS. I think MCPS, one of these topic will be asked, and they can ask you about any specific surgery, any specific like thoracotomy, but your approach should be the same multimodal approach, and just try to remember the 4 steps and tell some of the things from each step. And if any condition, in which there is some altered response because of altered metabolism or something, liver or kidney or something, you will just adjust it accordingly. Okay. So I think that's what at the end, just before finishing, this is just my luck that I have faced shingles about 20 years back. So I know what is shingles. And 1 year ago during Corona, I had this one wart develop in my finger, and it became so resistant, and I had multiple sessions of cryotherapy. And it was really, I was just thinking how it is used for pain, as a pain management. It is itself is creating so much pain. Okay, so this is how. And regarding opioids has sometimes very disastrous effect, and actually I didn't know that I was opioid sensitive. So one thing I remember, because we have now finished our discussion, so I can just say something, that how much these addicts enjoy their life. I had euphoria. I started laughing. I was bitten by a scorpion, and I had severe pain, and I received opioid. And actually, that is not a very perfect opioid. That's the which is available in Pakistan, this nalbuphine. But I had euphoria. I was feeling pain, but I was not. I was recalling everything, but I was not I was not able to perceive. So I can exactly explain what opioids does. Okay. So that's, I think we will finish here. And any important or anything Anyone wants to ask about this pain management? Because the one or two questions will come from the discussion which we have done. Most probably, yes. One thing please do recall is the pain severe assessment. It's because with the clinical and some scales, visual analog score, numerical rating scale, okay, and then faces in the different age groups. There are different Wong-Beckers and Flack scale. You should be having some concept about it. It's not possible for me to cover everything, but it is one thing which we actually missed. I just recall now. Okay, everyone, thanks a lot for your presence, and we will do something tomorrow, inshallah.
दुआ कीजिएगा सर कल के लिए.
Best of luck to all the people who are going for exam tomorrow. Okay. And TechnoSpark, Dr. Arif, please make sure you check your spark. Okay, because your mic is sparking like anything. Okay. Assalamu alaikum.
Thank you. Good luck.